The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Well, welcome to the Pediatric Lounge. This is your host, Dr. Herb Bravo, and with me is your co-host, Dr. George Rogo. Happy New Year, and may 2023 be a wonderful year for you, filled with love, good health, and bounty. For this, our 50th episode, we have a celebration and two very special guests. Dr. Hershel Lessin, who is a friend of the podcast and you all know well, and Dr. Jesse Hackel, who is a friend of the podcast, and they're both going to be talking today about what residency was like in the late 70s and early 80s. Dr. Lessin went to Yale, and Dr. Hackel went to Hopkins Medical School and Pediatric Residency. It is an amazing journey. They've seen many diseases which are no longer here because of vaccinations, the hard work of community pediatricians, the good fortune of America, and the pharmaceutical industry and their innovation, not only in vaccines, but antibiotics and public health measures that have eliminated a lot of pediatric infectious diseases. Please help me welcome both of our guests today. Hey, George, it's great to see you. How are you today?
How you doing, Herb? Today we have another day where we're going to elevate great physicians. We have Dr. Hershel Lessin and Dr. Jesse Hackel, both pediatricians, and we're starting a series of podcasts where we're going to be talking about the day in the life of a pediatric resident by decade. So we're going to start with the decades of the 1970s, late 1970s, and just see how life was, and then work our way up and see how life is today. Well, welcome, guys.
Thank you. Thank you, George.
Thanks.
Good to see you guys.
Likewise. Where are you joining us from, Dr. Hackel?
Right now, I'm in Manhattan.
Nice. And Dr. Lessin, it looks like you're in Europe.
Well, that's I think is on the Rhine, and that's in Budapest. That's the Capitol building. I am sitting at my dining room table, but I thought that would be more interesting than a.
I try to get backgrounds like that are real.
This one was real. We took this picture.
No, I try to be there.
Very nice.
My background's real too.
Dr. Hackel, why did you become a pediatrician?
Goes back a long time. When I was originally went to college, I was going to become a physicist, and got to college and couldn't handle the higher order mathematics. And at that point, having a strong interest in science, medicine looked good. And it was just sort of obvious to me if I was going to go into medicine, I was going to be a pediatrician. I don't think there was a whole lot of thought process behind it. It just seemed sort of natural. I had a good experience growing up with my childhood pediatrician. Kids are fun, and there wasn't much thought about being a surgeon or anything else.
How about you, Dr. Lessin?
Well, I'm kind of a little opposite, Jess, in that I wanted to be a doctor since I'm 4 or 5 years old, I think, and I always would say that. I think primarily because I wanted to be on the right side of the needle, because I was one of these kids, I'd run down the hall and they'd have to catch me. And I always wanted to do medicine. And when I got to college and medical school, the first thing I realized is I don't like adults.
Yeah.
I'll take a lot of clinging moms over one addict, narc-seeking back pain patient. And that's it, and it's fun. It's fun. You can act like a child, and you can do all sorts of things that an internist would never do.
Goes back to what I said about kids being fun. Absolutely.
That's right.
We do have the best job in the world, fellas.
Without a doubt.
And we are the most popular physician of the community. Everybody loves their pediatrician. You never hear it, I love my internist or my surgeon.
Jess, did you have a pediatrician? I had a family practitioner who made house calls.
I had a pediatrician since I'm 5 years old, Johnny Pisacano. He was about 4'8" and little Italian guy with a little beard, and he kind of looked like an elf. And yeah, he made house calls because I was one of 4 kids, and my mother only called the pediatrician if there was a problem. And they either said, come over now in through the back door, or we'll be at your house in a half hour, because they knew if she called, there was a problem. And as I got older, I had more of a relationship with him. And in fact, the summer after my first year in medical school, I had surgery on my shoulder, so I couldn't have any kind of occupation during the summer that would involve any lifting. But I spent about 6 weeks in his office just shadowing him around, and it was great fun. I mean, guy wore love beads and sandals. He'd swear at people in Italian, and some of the parents would swear back at him. And it just was great, and the kids were great. And like you said, being on the right side of the needle is always a good defense.
And all I had was a GP who would make house calls until I was a teenager, when I grew up in Sullivan County Catskills during the heyday of the Borscht Belt. And I didn't get a pediatrician until I was in my teens. And he was actually honored in our area. I'm still living somewhat close to that. And he got an award and I got an award. And we were both there. I mean, he was in his 70s or 80s, and I was in my 40s or 50s, and we met each other there, which was pretty interesting.
Yeah. All right, let's take this on.
So let's tell the audience what class in where you did your residencies.
Well, I went to medical school at Johns Hopkins, graduated in 1976, and then decided to stay on there and do a pediatric residency from 1976 through 1979.
Herschel?
And I went to medical school at Stanford, and I did my residency at Yale, and that's I was a bit of a fish out of water because I was always interested in primary care, and in those places, even back then, that was a tough thing to find.
Yeah, those were all the ivory towers. All right, first.
Well, who else trained pediatricians in America back then than Hopkins and the big hospitals like that?
Well, there were quite a few children's hospitals. I remember when I was finishing medical school, taking the grand tour. I went to Cleveland, to Rainbow. I went to Seattle Children's. I went to Children's of Los Angeles. Trying to think what other places. I went to Columbia, and I interviewed for residency at maybe 10 or 12 places.
Right.
And in the end, there were 21 residents coming in, and 6 of us were from Hopkins, had graduated medical school at Hopkins. So it sort of gets its hooks into you and keeps you there. And again, it was a high-powered place. And out of the 21 people in my intern class, I think I'm the only one who ended up in primary care, but that was not my intent originally. I actually started out training to be a neonatologist, did a year of fellowship, and then decided it wasn't for me.
Yeah.
Well,
Right.
Yale, there were, I think a handful of us actually went into primary care. They were trying to do some more primary care as it was. And we had a community hospital in New Haven, St. Raphael's, that we spent some significant time at. Plus, we were senior residents at Bridgeport Hospital, which was a large hospital with a pediatric faculty and program where we were sort of senior residents for a couple of months. So we got to do a lot of community stuff there as well. So they did make an effort. I do remember talking to my program director as I went into my 3rd year. And, we had a lot of heart transplants back then. It was big. And I told him, I'm never going to do a heart transplant. I'm never going to do any of this stuff. How about, I know my fellow resident who was definitely into that. I said, how about you let me take her outpatient rotation, and I'll give her my my ICU rotation, and we'll both be happier. The kids will get better care. And he agreed with me. So it was great.
Work, yeah.
And so I have to imagine that it was almost all men. The teachers were all men, and the residents were all men, or am I wrong?
I think based on Hopkins, you're wrong. I think my class of residents was about 50-50. And in terms of the faculty, there were more men than women on the faculty, but there were a significant number of really high-powered women. We had Barbara Mijon, who was an endocrinologist, Jean Kahn, who's a pediatric cardiologist, Kathy DeAngelis, who many of you have come across over the years, was there. You know, just a number of people who jumped to mind, having you know, had fairly illustrious careers over the years, were part of our Hopkins faculty, and in terms of women.
Was Frank Oski already there, or did he come in later?
Frank came later. John Littlefield was the chair of pediatrics at the time, sort of more of a footnote than anything else, I think. And Frank came a year or two after I left, I believe.
And we had, what's interesting is we had a lot of really elderly women who were the first women in their fields. One of the founders of pediatric cardiology was there. And then we started to get some younger women faculty coming in. I think our residency group was about a third women. It's not as, it certainly wasn't a half. But we did have a fair impact. I remember a young neurologist started just out of fellowship, started when I was an intern, and she's been there for 40 years now. And Ben and Sally Shaywitz were there. Sally is a big name in neurodevelopmental pediatrics.
And you mentioned pediatric cardiology, and if I neglected to mention Helen Tausig, who was at Hopkins, and at that, by the time I was there, she was already very senior. But you know, she taught us pediatric cardiology.
Yeah, it was the same way. I mean, Howard Pearson was our chairman. He was kind of a giant in pediatrics and pediatric cardiology, but he was one of these guys that when I was at Bridgeport and I needed to do a bone marrow and I was a little nervous, he drove down from New Haven and helped me with the bone marrow because he was on call.
Oh, wow. And so describe to me the clinical, because people, you know, younger physicians don't understand what it was like, right? There was no pulse oximetry. Everything had to be done with blood gases.
Yes, you probably had a more aggressive program with your every other night, but we would do, you'd go to work on a morning, you'd work till 7 or 8 o'clock at night, then you'd be on call, and then you'd work it till 7 or 8 o'clock the next night straight, and then go home for a few hours of sleep, and then work just another day, 12 hours, and then you'd start all over again.
Right.
And there were no blood gases. There were no CT. Well, I have a CT scan that was funny. Our new CT scanner was in a building a quarter mile away, and we had to wheel the newborns with all of their machinery through a quarter mile underground tunnel to get them. That was not a well-lit or well-paved tunnel. And
Right.
we would walk them over a quarter mile with all their vents and everything to get their CT scans, which was a newfangled thing.
And
What
so
was the
there,
day like? What was the day like with rounds and notes and Scutt Work and examples like that?
Well, yeah, as Herschel mentioned, the days were long. At Hopkins during my first year, which was not the first year of residency, of course, it was the internship year. We'd come in the morning, usually had to be there 7:30, 8 o'clock, see your patients, check on overnight stuff. And then we'd have rounds with the senior residents in the morning. We usually from 9 to 10, around 11, we'd have an attending rounds where you'd present cases. Noon, there was usually a conference. During the afternoon was our work time. But we worked every other night and every other weekend. And so we would come in on a Monday morning, and be on call Monday night and not leave until we were finished with work on Tuesday, usually at 6, 7, 8 o'clock. We'd come in again on Wednesday and stay and not leave until Thursday night. And then, I'm sorry, we'd come in on Wednesday and work Thursday night and Friday night. And then on Saturday morning, we would sign out to the weekend resident who came in Saturday morning and didn't leave until Monday night. And then, so that schedule would alternate where every other weekend you had a 2-day weekend where you could, basically sleep for 48 hours at home. And
Hopkins was renowned, Jess. Even
yes,
Hackel was the God. That's a brutal place.
yes.
I mean, we were pretty brutal, but we pitied you guys.
Well, I got to tell
your
you, it was tough, and you didn't have much time for any life, which
Did you
was
guys
okay.
get to have any sleep during the on-call times?
Hardly.
Yeah.
I was known as having a white cloud, and I used to have a fair number of nights where I would sleep, but we had the residents with the black cloud.
Yeah, I know them personally.
You'd go home one evening at 8 o'clock and they'd be on call overnight. You'd come in the next morning at 8 o'clock and they were like zombies because they had 6 admissions from the ER. And, they would just function on coffee and auto drive until they went home that night.
Right.
But, I tended to have a fair number of nights where I would sleep. Now, let me point out that sleeping when you're on call was not sort of like going someplace to the dormitory where you had a shower and a room. Sleeping was usually a fold-out cot in the resident's office on each floor.
Yeah.
They were hot. They were windowless. The nurses knew where you were, so they were constantly banging on the door if anything happened.
Sure.
So even when you slept, you didn't sleep. And those were the days also when, on starting our first internship year, you went down to the uniform room and they issued you 6 pairs of white pants and 6 white short jackets, and that's what you wore every day. So after wearing those and sleeping in them, and trying to get them back from the laundry, we all looked pretty disheveled most of the time.
Right. Yeah.
Well, I was 3 years later that I was at Yale from 79 to 82. And this was before the Children's Hospital was built. And we had almost the identical schedule you described with see your patients, get up to speed, resident rounds, work rounds and attending rounds and noon conference.
Yeah.
And it was the exact same thing. At Yale, though, what was really good is that no one other than the residents, including interns, were allowed to write any orders. So if a neurosurgeon wanted an order to do an LP, I had to write it, not him. He wasn't allowed. And there were no fellows, and I had to do the LP. And it was like that with every service. Only the residents, and I include interns as residents because that was my mindset at the time.
Mhm.
And we were the only ones
What was the reason
who
for
could write
that, you
any
think?
orders.
What was
It
the
was-
reason for that?
it
There was
was-
a reason for that.
Yes, the
We could
reason
take
for that was,
responsibility.
and it was training, and it made you really responsible for what was going on with the patient. And, that meant that the consultants needed to talk to you. They
Right.
needed to tell you what they wanted.
Unlike
Exactly.
today where they're incommunicado.
Yeah.
Right. But they used to talk to you. They'd tell you what you wanted. They'd say, I think this kid needs an LP. And you, as the intern, would go get the tray, go find a nurse to hold the kid, go
Right.
find the plates, because of course we dripped spinal fluid directly on culture plates there. We didn't put it into tubes and send
We
it
never
down to
did
the
that.
lab.
You're just really old, Jess.
Yeah, I'm old. We do the taps.
Yeah.
We'd do the plates. You'd have somebody who'd pass the plates because you were
Right.
gloved, obviously.
Mhm.
You'd collect the tubes. You'd pull the needle out and get the kid settled down. And then
Right.
you would take the tubes and go over to the nursing station and make the lab slips. You'd
Right,
take
that we-
and then you would take the specimens and walk them down to the laboratory because, you can't trust the escorts if you had escorts, because they may not get it to where it needs to go. And you just busted your chops to get an LP on this little kid, and you weren't going to take a chance of losing that fluid.
And the other thing we did, Jess, is that we controlled the beds. So if a surgeon wanted to do an elective tonsillectomy and I felt like I had too many sick kids, I would say, sorry, got to reschedule it.
We did not have
That
we did
got a
not
lot
have
of
that.
screaming from surgeons.
Yeah.
but we controlled the beds.
Yeah. Now, did you guys know all the lab results or everything that's going on with the patient, or did you say, hold on, let me look it up?
Now we look it up. Look it up didn't
Look it
exist.
up where?
Oh, yeah.
Finding out the lab results meant picking up the phone and calling a lab and waiting on hold while somebody flipped through papers to give you the numbers. So no, we did. That was part of our early morning rounds, was getting
Right.
the labs. I mean, we had clipboards or pocket
Peripheral
brains. Yeah, that had all the stuff. And I remember some people learned to handwrite in like 6-point penmanship because they'd carry 20 patients with all their lab stuff on a single sheet of paper on a clipboard.
Right.
But that was our morning. The morning was getting all that stuff from the laboratory. There were no computers that you could punch in the patient and get a flow sheet of all the labs for the past 12 days. There was nothing that got graphed showing progress. There was none of that stuff on the computer. It was all
Sounds
done
like
on
the
the
house
phone.
of God.
Well,
It was the house of God without the fun, I think.
I read The House of God when I
Yeah.
was an intern and about ready to cut my wrists. And I thought it was the funniest book I had ever read in my entire life.
Laugh out
Looking
loud
back
funny.
at it, it is so sick and so awful.
But is it
my
all?
God, it was my life, and it was the
It was
funniest
real.
thing I
It
ever
was some
saw.
real. You know, they have a second version
Yes.
of it.
Yeah, it's not good.
Electronic record.
I read that and I gave it to you, Hirsch, to read.
Yeah.
It's
Not
real.
good.
It's
It-
real.
So I have a couple of questions. So when you were a resident, did you go down to the lab to look at the gram stains and what was growing, and to the radiology department to look at the x-rays with the radiologist? Is that part of
Absolutely.
your morning routine?
Absolutely. We had, we did not only go down to the lab, but we used to do our own cell counts on those little chambers. We used to take the spinal fluid and go down in the heme lab and use a chamber to count the cells in the spinal fluid.
See, I think the early 80s were very different.
We
because,
also didn't
I-
have, I was gonna say, we also
I
didn't
never
have,
went to the lab to do anything by hand like that ever. We did, however, go down to look at the x-rays because you actually had radiologists who were still physicians back then, unlike being rote film readers that had no input on anything. And a good radiologist could save everyone's lives because they had this broad knowledge that you lacked, and they would discuss the case with you. And it was just so marvelous. And that's totally gone now.
we, in fact, that reminds me, when I talked about being in the ER, every morning, part of the morning work that we would do at from 9 to 9:30, one of the senior radiologists would come up to the ER, and we had one of those machines where the films were, and they rotated, and they would review every film done in the ER during the previous 24 hours with us. And so you learn to read films, and you got input. And these were, again, senior radiologists. John Dorst was one of the fathers of pediatric radiology, and he was at Hopkins, and he used to run these morning conferences. So we learned to look at
I
the
learned a little
films.
bit about radiology. Now, what
Yes.
about Scutt Work?
Remember
Oh,
the sound
God.
of these machines? It thunk, with the thunk, with the thunk every time that it flipped.
Well, this was a funny one. This was like, you remember those paper towel rollers they used to have in the men's rooms where you'd pull the towel and it would roll out of one side and back in on the other?
Yes.
Well, this was the same kind of thing. It was a closed loop, and they had these things, and you'd put the films on each row, and they would roll up, and then they would roll down. So you'd push a button, and the thing would go round, 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 until the film you were looking for was in front of you. And so, we'd see them by the bunches. They didn't leave the ER until we had reviewed them the next morning. And then they went to radiology, where they got read and filed. You were asking about Scutt Work.
Yeah, did you guys put like IVs or draw blood?
Everything,
God.
everything. We did not have a venipuncture team. We did not have an IV team. This was up to us.
Now,
And
what do you guys think? What was the reasoning for that? What was the purpose of that?
well,
One do one, teach one. I mean, that was the
No,
whole
but, I mean, you
concept.
came into private practice and you didn't do blood, you didn't put an IV. You got
Sure
really
you-
good at it after a
Yeah, we
while.
did.
sure we did.
Yeah.
I drew my
Okay.
own blood till I retired. Yeah, absolutely.
Well, I got smart and stopped doing that because because I lost my skills, and two, because we had nurses that were much better at drawing blood than I was. When I was a resident, I was very good, but that withered away. But we used to admit our own patients. There were no hospitalists. We
Yeah.
had our own privileges. If a kid needed a tap, you'd either do it in the office or you'd meet him at the ward and do the tap there. You'd start the IV, and you'd pray you could do all that
Yep.
to get the care going.
Remember, in the community hospitals where we were going, we didn't have those. We weren't going to have those things. And so we needed to have the skills. But I think back in the day, it was a question of that, you know, this is what you do. This is,
Yeah.
you're a doctor. You do everything you need to do for the patient.
Right.
And, you know, when you look back on it, the amount of time I wasted trying to put lines in some kids that I could have spent more productively. And yet I still managed to learn a heck of a lot during those times.
You know,
But
I
You did
think
have an
those things-
appreciation when the kid got stuck 4 times and you were doing the sticking. You
Yep.
got an appreciation for how torturous that really was.
Yep, you got to see it and you got to understand what the kid was going through. And,
Right.
you know, especially when you had those kids who were tough sticks because they had been around and with chronic disease, you understood what they were going through. It wasn't a question of sending somebody from the IV team to do it while you went and did something else. And
Right.
again, was it a valuable use of my time? In a lot of ways it was, and in a lot of ways it wasn't. I think there's a balance there.
Yeah.
But I can still draw blood on a newborn probably better than most people because I've done it so many times.
I think there was some value to these things, not much, but it did help you to overcome fear
Oh, yes.
of children. 1, 2, you had to do a lot of blood sticks and IVs and things like that. And then you had to do education. You had to do the admission. You had to do the work and examine and
You had to write it
Maybe
up.
time
These were
management.
page-long
it helped
admissions.
you to multitask and be able to just do everything at the same time. So
Keep
there's some
a-
value to it.
And keep a lot of stuff in your head. And,
Yeah.
you know, there was a lot of that going on. And you were keeping 12 patients in your head and who needed an IV. And you had to prioritize too. You had to get to the most important ones
You had a
first.
Scutt list with check boxes,
Yep.
and you'd check off each IV, each blood draw, each LP, whose admissions you hadn't written up yet, which attendings you had to call. that
So it
sort
made
of
you
thing.
organized.
Yeah.
Yep,
Yeah.
absolutely.
Made you organized and multitasking.
I
And when you
trained
say
later.
overcome fear,
Yes. But I trained
I mean,
later.
I
later
swear to
than that.
God, beginning of my residency in the ER, I got a call and I thought I was being pranked, okay? Because they said a busload of hemophiliacs just crashed.
Oh,
And they were coming to my ER. And I kid you not, that actually happened. And, you know, I had a kid who came in with walking down the streets near the hospital who had a 14-year-old who had a bullet hole right in the center of her head. And she was sitting there talking to me. And the only thing I remember about that was I tried to stick a 14 gauge IV into her wrist and I wasn't very good. And she bled all over the place. And she actually had a miraculous survival because it went right up the sagittal sinus and didn't cause any brain damage. And I visited her in the ICU, which someone would never do these days. And she said, I remember you. You were that doctor who made that big mess of blood on the floor.
So I trained later than you guys, but what I got from all these lap draws is it taught you humility. No matter how good you were going to miss sometimes. And it
yes.
taught me teamwork. Sometimes somebody would say, you're really good at, I don't know, suprapubic taps, or you're really good at, you know, sticking little kids with IVs. Why don't you do that? And I'll do this for you. It was it was teamwork. Because some people are good at one thing, others were good at another thing. And so there was a sense of teamwork. I wasn't very good with little kids, with the newborns. I wasn't very good at drawing their blood or starting their IVs, but anything else I could do. And I love going down to the lab and with a radiologist and looking at the plates and looking at the gram stains with the techs and knowing exactly what the biology of the disease that my patient had. And I would tell the tech, well, this is what's going on with the kid. This is what the kid looks like. And that human interaction was so much fun for me. Unfortunately, in the terms of efficiency, we've done away with all of that.
Right.
Sometimes
a
you thought
question
you knew
for you.
better than your attendings. And unfortunately, you did a lot of times. I mean, I had an attending who was a subspecialist who literally knew nothing about anything but his subspecialty. So he was forced to do ward rounds. And nobody wanted to present to him because he'd make idiotic suggestions, and we had to find a way to not do them because he didn't know what he was talking about. And I was of the era when steroids with croup were verboten. No, you can't use steroids for croup. They don't work. And anyone who'd ever taken care of croup directly knew, yes, they did work. And so we would give them even when they told us not to. And you get blowback, but it wasn't terrible blowback. And the kids got better.
Yeah.
Right.
Did you guys have to wear ties in the morning, like at 7 in the morning? Did you have to get it buttoned down in a tie to do
Sure, along with the white pants and the short white coat. Yes.
No, we had nothing like that.
And we didn't, if we wore scrubs, it was because we stole them out of the OR. We did, and they were stamped all over property of Johns Hopkins Hospital.
Yeah, I have a whole bunch of sets of those from
Yeah,
more than
but
40 years old.
these days of pastel colored scrubs embroidered with the name of your unit and your own name and the fleece jackets that everybody wears. We had none of those freebies, none of those perks. So yeah, it was a tie, and which I continued into the first several years of my practice.
Yeah, we didn't have to wear ties, but we did have long white coats. And you needed it because you needed all the pockets to hold your Harriet Lane handbook, your peripheral brain, your Scutt list, everything else you needed to do. And you just had to get it all done. You couldn't leave till you were done.
Right.
What was the purpose of the?
I used to tell the docs who work for us, this is not a bakery. It's not, you come in, taking an order and take a number, and we're closed now in the office. We were open till we were done. And that came from the training that we had, because you worked till you were done and you took the sick people first. And that's, again, very foreign from the mindset you see today.
Correct.
And so as far as technology and subspecialties, the cardiac ultrasound was just in its beginning stages. So was the MRI in the 70s, right?
I don't recall an MRI, but I recall a
MRI.
CT scanner, like Herschel said, down in the basement a long way, and they were slow, and you had to sedate most kids. So you were pushing Valium on these kids and standing by with an ambu bag for when you overdosed them and they stopped breathing inside the big CT scanner. There's other technology. Somebody mentioned pulse oximeters. I think the first time I saw one of those was after residency, and it had this Band-Aid tape, and you had to position the laser in the right place, and it never worked well. We used to draw our blood gases, and at the NICU at Hopkins, we had a machine that was all pipes and tubes, and you had to adjust and you had to calibrate, and there was bubbling going on. And, we used to draw capillary gases. You'd heparinize a tube, and then you'd draw the gases, and then you'd run them in the machine because, you couldn't get them to the lab without them clotting. After a while, they had these syringes that you could do a radial artery stick on.
Yeah, we did radial artery sticks. We hated them because they scared the pants off us. And, and if it clotted, boy, you wanted to really cut your wrists again because it was so terrible for the patient.
And the bilirubinometer that we used to have to calibrate, every time you ran a sample, you had to run a control on it. And these were all in the back room of the NICU. We did all of this stuff. Point of care testing is a new term for what we used to do. And once the hospital figured out that they could bill for this stuff, they took it out of the NICU, and then we had to use the lab for it. But we used to do it ourselves, working in the NICU. And you mentioned asking what the clinical years were like and what experiences we had. Well, one thing I remember is that we had, in the space of 36 months of residency, we had at least 6 months of NICU. And there was a
lot of NICU.
Tremendous amount of NICU work that took away from the outpatient experience, that took away from the inpatient general experience and stuff like that.
And we had NICU and ICU. Our ICU was pretty much a post-cardiac surgery ICU, except for the infectious diseases. So we would be having several heart transplants at a time. We had a heart transplant surgeon at Yale who was world renowned, and he did a lot of work.
Yeah.
Okay.
What about the ER? Did you guys do any work in the ER?
Oh,
Yeah,
sure. The
course.
pediatric ER was first year you were in the pediatric ER, not the outpatient clinic. Second year you did the outpatient kind of walk-in clinic, more like an urgent care. And then third year you were the supervising resident, again in the pediatric ER.
Now we had at our ER, there'd be two of us there at night sitting at a little desk, and we didn't have a separate ER. It was part of the hospital ER, but we had our little space, and that's where they would bring the kids and we'd take care of them. And there was no attending there. There was nobody. If you needed help, you called the attending, or more likely you called the chief resident, because they actually knew what they were doing and they were hands-on, whereas the attendings of marginal value sometimes. So you got to know how to make hard decisions, how to react in pressure situations, and how to get everything done that you had to get done. And it was your responsibility, which caused you to feel bad a lot of times when you weren't as good as you ought to be.
During our second year of residency, we had one second-year resident who was the overnight, who worked 11 p.m. to 8 a.m. in the ER by himself. He had no attending, he had no senior resident. However, each of the units, each of the inpatient units, and at Hopkins there were 3 big ones, each of the units had a senior resident and 1 or 2 first-year residents every night. So there were plenty of senior residents in the hospital. And if you had a kid come into the ER who was either going to need admission or you couldn't handle, you had plenty of backup within the hospital from your seniors, and you'd call them and they would come down and help you.
And the chiefs
just as
would always come in.
And the chiefs were there
Always.
all the time,
I mean,
24/7.
they worked harder than the interns, I think.
Yeah. So, but I
And,
think
you
this is the time before vaccines. So do
Well,
you?
not before vaccines.
Well, no,
We did have 3 vaccines.
We did have DPT
Yeah, Ben.
DPT and polio. We had 2 vaccines.
and the MMR, I think, came out.
Yeah,
in,
it came
yeah.
in the 60s.
But the acuity and the severity of the illness had to be a lot more than it is today. Runny nose. What are we seeing today? Cough, cold, runny nose, and sore throat.
When you'd see a kid with a fever and
Yeah, I
a
was just gonna
croupy
say that.
cough, you didn't think croup. You thought epiglottitis, which is
Yeah.
Haemophilus. When you saw a kid with a high fever under 2 years old, it was rule out sepsis
And
because
rule out
they had
meningitis.
invasive pneumococcal and invasive Haemophilus
time.
disease. So we were doing taps in the ER. We were doing cultures in the ER. We were doing
We would
white
get blood
counts.
cultures on everyone, because I was involved in Paul McCarthy's original studies on trying to decide who do you decide is sick by looking at him. And he did a whole series of things. So we had criteria. You have to have a CBC and a SED rate. And from then you decide whether you wanted a blood culture or a tap. We do suprapubics all the time. And it was like the dark ages. And these days, can you remember walking every kid with croup to the radiology to get his lateral neck with a laryngoscope in one hand and a tube in the other?
Or to the OR to get intubated.
Yeah. And it was scarier than heck. And every kid with fever, you had to worry that invasive pneumococcal disease. And no, you can't even imagine the burden of that when you see how many sick kids with fever these days. Can you imagine if you had to worry that they were all septic and all had meningitis and every bark and cough was epiglottitis? And it's inconceivable to most docs who trained today, because we have all these vaccines.
Which
Yeah.
is one of the problems with vaccine hesitancy, is that the people who are being trained today don't recognize what we're preventing. They don't recognize the severity of the diseases that we no longer see, but that Herschel and I had experience firsthand with.
When
But
we had the
those
measles
diseases can
outbreak
still
in
knock on your door.
93.
Those diseases can still knock on your door.
Oh,
They're not
absolutely. We had a measles epidemic in 1993 when, they were finally figuring out that maybe you needed a booster. And we had measles a lot.
Heck,
And
in
even then, the
93, I
younger
think I
guys,
caused that epidemic. I was working in the ER.
1993,
I
I'm
had
sorry, not
measles.
63, 93, but
93, yeah, 93. I was an intern in Jersey
yeah.
City, ER working. We were full of measles.
And, you know, in the office, holy crow, I mean, nobody recognized measles then. Even the
Right.
younger people then had never seen measles, and it had been a while since I saw it.
Yeah. But then as it came, everybody knew, oh, you got measles. Oh, it was funny because I got sick. It was the only day that I called out for sickness in work. I went to work, I passed out. They admitted me to the adult side, and they were thinking of all these weird diseases. And then one of my colleagues that was working, he walked in and says, oh, you look like all those kids that were admitting. Sure enough, it was measles.
Oh, that's rough as an adult.
Yeah.
Yeah.
So not only did the vaccines change the practice of medicine, our arsenal of antibiotics also changed the practice of medicine, right?
Oh my God. Do you remember using
Well,
chloramphenicol and worrying that every kid you put that on was going to get aplastic anemia?
Correct.
yeah, you know, yes and no on that, Herb. I mean, look where we are today. About the only thing we have to use, at least in the outpatient setting, is amoxicillin, if you can even find it. We don't have a lot of outpatient antibiotics that we can use anymore. The inpatient world is a different story, absolutely.
Yeah. There's no money in outpatient antibiotics because they're
Right.
short term and nobody can make any money because they're not on it for 6 years. They're only on it briefly. So it's I don't think the antibiotics made that much difference, but I remember Clorox. We used to do that with periorbital cellulitis, was oxacillin and chloramphenicol, because that's what we had.
Wow.
And I
Now,
remember using theophylline. You say
Sure.
theophylline to anyone
Correct.
who was trained within the last 20 years, they'd go, what?
Yep.
And you didn't realize that you went from therapeutic to seizures in no time.
that's right.
You had to be very careful.
That's right. So I think some of the antibiotics, I don't like Rocephin because you know, people don't think when they use it, and it's a mega bomb. But it didn't make life easier. You could give Rocephin IM if you didn't have IV access, as opposed to giving, you know, antibiotics every 4
Right.
hours.
Sure.
It was nice.
IM Rocephin helped a lot in the office when you could take a kid and saying, well, I got 24 hours of IM Rocephin. I'll see him tomorrow rather than admitting him.
Yes, and if these febrile UTIs are yet to admit and be monitoring gentamicin levels so they don't become deaf, and you don't
right.
destroy their darn kidneys. And now I can just say, if I'm gram-negative, if I use Rocephin once a day IV, I'm covered. I might not have to put them in the hospital. I might just be able to watch them in the office every day. And I think that made a difference in, you know, how I was able to take care of my patients. I didn't
Well,
like
you
it
know,
how
one-
the ER, you know, everybody with a fever got a shot of Rocephin
Yeah.
to cover their rear end and out the door.
vitamin R.
Vitamin R.
And right came vitamin Z later.
Yep.
Luckily,
Yes.
vitamin Z never worked. But I remember being in the NICU. We had a big NICU. Yeah, we had like 50 beds. And you know who covered those beds at night? One pediatric intern and junior resident and one OB junior resident. And then you'd have a second-year resident around. And if you were desperate, maybe a fellow. And
We've-
that's it. I had 6 kids die in one night.
Oh my God.
Okay. Again, another reason why I'm surprised I'm still working.
We
It was
finally
terrible.
got neonatologists during my 3rd year of residency. Until then,
Oh, really? Yeah,
we
had
didn't have.
we had neonatologists.
And the NICU was on the 5th floor of the children's hospital, and the delivery room was on the 5th floor of the women's hospital. But they didn't. They only connected on the 1st floor. So when we had a stat page for a difficult delivery, we'd run down 5 flights of steps, run across the other side of the block, and then run up 5 flights of steps. And they were resuscitating pediatricians at the same time.
Well,
They
at
were
least you had a
resuscitating
children's
newborns.
hospital at Yale. They just were thinking about building the children's hospital my
Right.
senior year. We had no children's hospital. We had multiple ancient buildings set apart. So when you were an intern, you would cover the entire infant floor, 40 or 50 beds by yourself, or the entire little kid floor, or the entire adolescent floor, and you'd be it. you'd be the intern, and you might have some backup with the second-year residents who were
Yeah.
floating around.
Do you think that
and
was good?
You were it.
Was that good?
Is that good? In one sense, it's good because you sure learned how to do things properly.
Right.
And as long as you felt comfortable getting backup and you could get it, then it was great. If you made a bad error, then that could have very bad consequences.
Correct.
And, you know, that sort of was sloughed over a bit when you talk about when men were men and all that stuff that you're hearing from us. But it was problematic to some degree when you, when you were uncomfortable.
Yeah, I mean, I think as I look back, patient care was pretty good. I mean, we were well staffed. Each floor had a senior resident and 2 first-year residents on call every night. So you had people around, and with 40 kids, there was plenty to do. But I don't remember too many egregious episodes because we did have the backup, and we knew it was on our shoulders. And if you were up all night doing this stuff, that was part of the game. That was what you were there for.
Absolutely part of the game. No, everyone was chronically sleep deprived. We had call rooms, which you didn't. It sounds
We did not.
We had separate call rooms, and I could sleep anywhere within seconds. And even it was only 10 minutes, boom, that was it.
Now,
So,
did you guys have pagers, or it was all overhead?
It was overhead for us.
we had I think we started overhead, but we had pagers.
The radio pagers, right? The ones that
yeah,
the voice
yeah.
came through.
Right.
They were just a beep. No, it was just a beep, and then you had to call the operator and find
somebody.
out where they wanted you.
Yeah.
And then we got the alphanumeric things, which such a great advance. You could actually see who was calling you. It was marvelous.
We never had that, and most of the time for us it was the overhead. At 3 o'clock in the morning, the floor was quiet, and all of a sudden you hear Dr. Hackel to the ER stat, and it would broadcast through the entire hospital, and you'd go running down, and everybody would look and say, "Oh, that must be Dr. Hackel."
Oh my God.
Now, what'd you guys do about notes, progress notes? You know those things?
About what?
Progress notes.
You wrote them, or you didn't
wrote
go
'em.
home.
You wrote them. That was part of the job.
Yeah, there's a lot
They
of
were
notes.
real notes, not this cut and paste EMR nonsense you get now. You
Yep.
actually wrote about things that happened and things that mattered, and you actually wrote a narrative most of the time. At least the pediatric people did. The surgeons, not so much, but we wrote.
And because we were doing the writing, we had, especially at 3 o'clock in the morning, we had some incentive to keep them short, to keep them concise, and to actually convey some data that was relevant. Of course, not everybody had handwriting that was readable to somebody the next day, but nonetheless, they were written out longhand.
Yeah,
Yes.
it takes a long time to write. I mean, just writing a page of something,
Took a long
whatever
time,
it is.
and
the
admission was a
alphabet.
big deal.
Yeah,
Mainly, just like today with the EMR paperwork, we had paperwork, and we had to get it done. But you really learned stuff because you were it,
Yep.
and the buck stops here.
And
And it's trial by fire, but the buck stopped here.
And I will say that the best part about being there for many, many hours is you actually got to see disease progression. When you started a kid who was wheezing on an aminophylline drip, and you get to listen to him every couple of hours, and you could see how things were evolving and how things were clearing or not clearing. When you had kids who were really sick, and then the antibiotics finally kicked in and they started to recover, you could actually watch that happening in real time. It made a huge difference.
The outpatient training was pretty pathetic. I mean, we had 1 day a week of continuity clinic.
yeah.
And, you get to see 3 patients, and you consider it a busy afternoon, and you had to present to everybody. And it was interesting. I think that they were much more nervous about you taking care of outpatients than they were about you taking care of inpatients.
Correct.
And you
Well,
didn't get much training as an outpatient. You had
I don't think that they're doing it's any different today.
I think people have continuity clinics, but I think they so often get interrupted by the need to do other inpatient work. that I don't think they have it. We did have a lot of outpatient sick care,
Yeah.
which was essentially a walk-in clinic in the community. But what we didn't have was the continuity and the following a lot of kids. I followed more kids for 3 years through the oncology clinic than I
Right.
did through any kind of continuity clinic.
Yeah, there wasn't much real continuity because, as you said, you had other responsibilities. That outpatient was the bottom of the totem pole. You know, that was the first thing that would go.
I don't know, but I remember when I was a resident intern at Jacoby in the Bronx, I worked a lot in emergency room. We saw everything. And when I came out to Cushy, Long Island, and I was on call by myself, I said, ooh, this is easy.
Sure.
Now my job is really, really, really hard. I don't know. Seems that's what it looks like. People have a hard time adapting.
So did you guys follow fever curves? Remember the fever curves on the chart?
No, not really. You'd kind of do a point in time assessment, you know, with
Yeah.
what was the fever now, what was it later. I don't
How
think
many times did you get called in the middle of the night that baby Smith has a fever and you'd have to come down and do a CBC and a blood culture on him, even though he'd had 6 of them before, and he just did it again?
Yep. Anybody under 2 months got that done, and no matter what they were in the hospital for. We did
Well,
sepsis
everybody got it
workups.
done. Anyone who spiked a fever, post-op,
Yep.
infectious disease, when there was a new fever spike, you had to do something.
And in the nursery or the NICU, well, you know, if kid looked at you funny, got a sepsis workup.
Absolutely.
And that was our job. We were the interns. We got called to do that.
And when you did rounds, was there a chief nurse on each floor that did rounds with the team?
Usually,
Yeah,
not always, but usually. I mean, you know, just we had some phenomenally good nurses, and we had some phenomenally poor, irritating nurses. You know, the ones who would knock on your door in the call room after you just put your head down and say, he has a 99.9, can I give him Tylenol?
Yeah.
Versus the ones who knew when to bother you. So like anything else, but you know, they would come around, and there was not a lot of nurses taking initiative as much as we see today. But we did have some good nurses who could recognize sick kids and let you know. And it was a stupid intern who did not respect when the nurses said, I think we have a problem here.
And we learned how to look at a sick kid and say, this kid looks like garbage. And that, you know, I was involved with those studies with Paul McCarthy. So that was beaten into our heads, is you look at a kid and you say, this kid looks bad. Now let me find out why, as opposed to this kid looks okay and I'm not so worried. And that's a skill I don't see that much anymore, because first of all, they don't see that many sick kids, and they don't get an appreciation for what looking sick means.
Right. And, you know, we still have that. You can assess a kid who was in your office. You can assess a kid within the first 10 seconds,
Absolutely.
whether there's a problem or not. And that's something that, you know, that's experience. That's the overnight experience, and seeing these kids at 3 o'clock in the ER in the morning. And that's the experience of seeing a kid in the hospital who's not improving the way you think he should. And you just know there's something wrong. And then you start to formulate a differential and try and figure out what exactly it might be.
What's wrong? What's making this kid look so terrible?
Well, the day of the dinosaurs, I guess, right?
Yeah, you know, listen, I prefer to think of it as the days of when giants walked the halls. But
Okay.
But, you know, it was much harder than it is today. And, you know, I think it had pros and cons. Trial by fire makes better warriors, if you know what I mean.
That's
And
if you
it was
survive,
good in that regard. What?
if you survive the fire.
Yeah, but we had a couple residents who left the program because they couldn't survive the fire.
Sure.
And
Absolutely.
I actually was thinking about doing a derm residency, but they wouldn't let me leave. So, you know, but it really was a trial by fire.
Yeah.
And, you know, I think it made us who we are. It trained us well. It's a different world today. I don't miss, having to do the scut work. and having to draw all the bloods and carry specimens to the lab and
Yeah, that was nuts.
look up stuff because now you got it all on the computer in front of you. So,
Harriet Lane, I mean, that was the Bible.
yeah, it's also tripled in size, I think.
I know, it's appalling. It used to fit in your pocket. Now you need a briefcase to carry it.
Yep.
So.
That comes out of Hopkins. It's published every couple of years by the residents at Hopkins.
It was great. It was great. That was gospel.
Wow. What wonderful times, you know?
Yeah.
I am glad that some of these infectious diseases have gone away.
Oh,
For sure.
For the kids' sake. For the kids' sake, right? This is
for our sake, for the kids' sake, for society's sake. When pneumococcal bacteremia vanished, that was like the load of the world was taken off your shoulders. And when measles, mumps, and German measles vanished, that was a big deal, but nowhere near as pneumococcal disease.
Right.
That was the biggie. And plus the fact you don't see ear infections nearly a quarter as much after pneumococcal vaccine. They speculated that that might be true, and it was true.
That was definitely true.
Same with
And chickenpox
Haemophilus.
vanished. Jess, how many times did you have to have a chickenpox kid when you had to bring him to the office, come in the back door in the side room?
Yep.
Now
Absolutely.
nobody knows what chickenpox looks like.
Absolutely. It's things like that that make a difference. We're seeing a lot less infectious disease.
Serious infectious
disease. We're seeing a lot of, like you say, fevers and sniffles, and the flu and COVID and human metapneumovirus. All these viruses that now have names that we used to just call, oh, it's a virus.
Right.
We're seeing that the same way we did, but taking the edge off where we're not worried about, every 6-month-old with 104 fever is having sepsis is a huge advantage.
Oh, it's amazing.
And it's been replaced by stuff that I couldn't have imagined early in my training, molecular diagnostics, molecular treatments, all these drugs that end in MAB or IB or stuff like that I could not imagine. I mean, treating kids with Crohn's disease and ulcerative colitis, without taking out their colon. I mean, things are a whole lot different of stuff that I could never have imagined back then, because it's we were worrying about the alligators while we were trying to drain the swamp.
And one of the stories I tell about residency that tells you the difference between today and then, and I think I said it when I got the Buzzy Award a while ago, was if you go into an OR, because we went to all the deliveries, or if they'd say meconium, and then what you do as a resident is you'd grab a tube, you'd intubate the kid, and then without any barriers, you put your mouth on the end of the tube and pulled it out and went, and you'd often get a mouthful of meconium. And when I told people that, they literally do what Herb just did, was, holy crap, how could you do that?
Routinely, absolutely.
Routinely.
Well, then they advanced to aspirators.
Yeah, and then
we had
Deleuze after a while, and now they actually have suction that usually works.
Yeah, but our suction was all oral.
Well, I did that on my own son when he was born. So I mean, that's 42 years ago.
I resuscitated my son also, who was a preemie, and he had a crash C-section, and my partner wasn't in the hospital, and there was no one there. So I was it.
Oh my God.
Yeah. And I did the spinal tap on my daughter when she had a fever at a week of age, because my son had Coxsackie when she was born. So, listen, we've been there.
Oh, wow. Well, it's been an amazing journey, right? In '89, when I started, the life expectancy, I guess the oldest survival was a male with CF in his 30s.
Sure.
They died in their early teens.
Yep.
Yep.
And today there's a whole bunch of adults with CF living, quasi normal lives. It's not totally normal, but it's like having diabetes. It's a chronic illness, and as long as you take care of yourself, you survive and you have a long lasting life. That was unimaginable. It's a miracle.
How about the new specialty of adult cardiologists taking care of adult survivors of congenital heart disease? My partner had a daughter with complex congenital heart disease who survived into her 40s. That was unheard of back
Yeah.
then.
Yeah.
But, the difference in residency really was you took responsibility for everything, from the most minor detail to intervening and to save a kid's life. And you did it often, you started it often before anyone was there to help you, regardless of your level of training. You did what you had to do. And if you had enough brains, you'd call for backup. And that's the difference, is that when we were trained, we did everything. We don't have fellows. Not every wheeze needed a pulmonologist. Not every murmur needed a cardiologist. We took care of everything, and we made judgments, and we learned how to decide on the spot and not dither quite as much as we all do today.
And we learned how to use the resources that we had, because we didn't have cardiologists just looking for business. So we learned which murmurs were innocent and could be safely ignored. And you learned that by listening with the cardiologist enough times and then pointing out to you the characteristics of things that needed to be referred and things that didn't.
Interesting.
Amazing. It's just
All
amazing.
right. That's cool stories.
But you were exhausted, let me tell
Yeah.
you. I mean, exhaustion and recriminations that you could have done a better job were rampant, because most of us really wanted to do a good job, and we're, relatively bright people. And if we didn't do a perfect job, we felt bad about it.
Yeah.
And we didn't leave until the work was done. And
Absolutely.
we knew what we had to take care of. They were our patients, and we were responsible for everything down to the documentation and the paperwork.
Yeah, I think what's really changed, and the, I'm not just talking about physicians, is that concept of it's my responsibility. It's
Right.
on my watch. I own this until my call is over and my colleague comes in, and then they own it. And that responsibility that this is my patient.
I mean, we also develop relationships with some of our patients, particularly, kids with chronic disease. I remember being off call on one of those weekends when I had the 2 days off, and I had a 15-year-old with leukemia who was in the PICU dying. And while I was out, I was checking in with the PICU. And after dinner on Saturday night, I went back to the hospital to be with him and his family when he died. There was that as well. That
True.
came from following these kids, at least through the 3-year stint that we were there. You'd pick up a newly diagnosed child with leukemia, and he was yours to follow. And you'd meet him in the oncology clinic, and you'd do his bone marrows, and you'd talk with the oncologist about his treatment regimen, and you'd follow him, and they'd know to call you if they had a problem, and
You'd
you'd
be
see
involved. I
You'd
had a
be involved.
15-year-old whose older brother was a puppeteer for the original Muppet shows. And he would come in with his Muppets to do just to entertain everybody. And I remember that we had to withdraw support for him finally, and everybody was there. And, it was awful and wonderful at the same time. And I don't know that you see that kind of continuity anymore.
Yeah.
You don't, because society is not about relationships anymore. It's very transactional.
To a large degree, you're right. I think that's carried over into medicine as well. The job's not done because it's 5 o'clock. The job's done when everything is tied up and packaged neatly and stable.
Right.
Yeah.
Not a bakery, as I said,
They want it to be.
We're too worried about what CPT code to use. And
Well, I was going to say,
Oh my
that's
God.
interesting. The one thing we did not think, not once, not one single time about, the one thing
Ever.
we did not think about was billing.
Never. When I started practice in 1982, we had 2 visits, office visit and recheck. That was
Yep.
it.
That was it.
One was $25 and one was $15. And we had checkups too, but that wasn't covered by any insurance. And so you would try to make up, everyone had a rash so that their well child care could be covered. I mean, it was just crazy. And it's devolved from that.
Well, Well, this was fascinating, and I think this sequence of podcasts is going to be very popular once we start going down the the generational track. I think Herb and I are going to find people in the 90s. It's going to be pretty easy to get those guys. 2000.
Yeah, there aren't too many of us left.
Yeah, it wasn't easy. Well, I thank you guys,
It's been a pleasure.
and just spread the word, and as the kids say, like us, subscribe, click, do it all. Let's elevate great physicians.
This has been wonderful. Thank you for your time, and thank you for everything you've done for society. It's really been a wonderful hour.
It's been great talking with you.
It's a pleasure.
Great, it's been great reminiscing. I sort of thought about this
Yeah.
for the past couple of days, and had a lot of good memories come back.
We'll share this one.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.